Good afternoon, and welcome to our virtual town hall. During this session, we'll answer your questions and provide trustworthy information about the COVID vaccines. I'm Dr. Lainie Rutkow, a professor in the Johns Hopkins Bloomberg School of Public Health and senior advisor to President Ron Daniels. I serve as one of the team members leading our COVID planning efforts. I'm delighted to be moderating today's session, and I'm joined by my colleagues, Dr. John Links, who's a professor in the Bloomberg School of Public Health, Vice Provost and the university's Chief Risk and Compliance Officer, Dr. Anna Durbin, Professor in the Bloomberg School of Public Health, and Brittany Feijoo, Nurse Practitioner and Research Associate in the Bloomberg School of Public Health. Before Anna and Brittany's opening remarks, I want to mention the Johns Hopkins Get the Facts About the Vax campaign. For those of you on campus, you've hopefully seen materials related to this effort. It is a great resource for clear and accurate information. The campaign focuses on how we can all protect ourselves and protect each other during the COVID pandemic. Getting the COVID vaccine is a key way to keep both ourselves and our community safe. In addition, during this session, you'll see a banner on your screen, and it's for a voluntary anonymous survey. We hope you'll complete the survey to help us better understand the concerns of our affiliates. And to be clear, participation in this survey is voluntary and anonymous. In our announcement for this session, we ask that you please send us questions beforehand, and we appreciate the many that we've already received. We'll be providing answers in real time today, so please submit your questions in the box at the bottom of your screen. This town hall is being recorded, and it will be available for asynchronous viewing. I'm now going to first turn to Anna, who will give us some brief opening remarks about the COVID vaccines. Anna, over to you.
Thank you. So my apologies. I had a little computer glitch there, but it's really my pleasure to be back and to talk with you all. I think we've made tremendous progress. I was just thinking about what's happened in the past week in terms of our efforts. Really important and thrilled to say that 60% of American adults have received at least one dose of the COVID vaccine, which is fantastic news. I think it's about 75% of those 65 and older, which is also very good news. We're seeing progress being made in our fight against COVID, and I think significant amount of this is due to the vaccines. We had new guidelines released last week from the CDC. We had EUA given to the Pfizer vaccine for children 12 to 15, and we're starting to see children become vaccinated now. Both Moderna and Pfizer are evaluating the vaccine safety and immunogenicity in children younger than 12. And we've seen even Montgomery County in the state of Maryland relaxing some of their COVID restrictions. I think that's all good news, but I think we have to remember that we don't want to have a backslide. We need to keep vigilant. We need to use common sense in terms of masking and social distancing and follow the guidelines that are still in place. And I still encourage everyone who's eligible and hasn't been vaccinated to get vaccinated. Thanks, Lainie.
Thanks, Anna. I'm now going to ask Brittany to make some brief opening remarks about the types of questions and concerns that she's encountered as a healthcare provider who routinely speaks with patients about COVID vaccination. Brittany, over to you.
Good afternoon, everyone. And it is also a pleasure to be on this panel today. Since the fall of 2020, I've been working alongside Dr. Anna Durbin and Dr. Kausar Talat on phase 3 COVID-19 vaccine trials with both the Pfizer and the AstraZeneca studies. And COVID-19 vaccines have definitely brought about a lot of dialogue in regard to vaccine hesitancy and vaccine acceptance. One of the major concerns early on in the vaccine rollout is that individuals who are most at risk for severe COVID complications and death would be less accepting of the vaccine. As a nurse practitioner and a researcher, I strive to provide clear and consistent messaging surrounding the vaccines, while also acknowledging the fears and concerns of patients. What has been extremely interesting and somewhat novel in a sense for me is that this is the first time that I have been involved in a vaccine trial and then months later been involved in administering the vaccine to the general public. As you would anticipate, the perspectives and motivations of volunteers in COVID-19 vaccine trials are much different than individuals who are now currently considering vaccination. The majority of concerns from patients involve the overall safety of these vaccines and, of course, their rapid development. The emergency use authorization and lack of this full approval or licensure also brings forth questions from patients. I often get asked, why should I trust it is safe when it was developed so fast and they didn't test it long enough? Well, when addressing these concerns, I emphasize that safety was not overlooked or compromised, that these vaccines were developed at such rapid pace because researchers already had a good foundation and background on coronaviruses, such as the MERS, Middle Eastern Respiratory Syndrome, and also SARS-CoV-1. The mRNA technology also allowed for this rapid deployment because only the genetic material from that spike protein was used and not the entire virus itself. Another thing that I like to mention is that financial burden that typically consumes research was lifted as the federal government fully funded a lot of this research. This allowed for easier transition through the trial phases and not hold up kind of on the process that typically take place with waiting for data and waiting for analysis and then funding to occur. Another question that arises is a conversation involving fertility, specifically with female patients. They ask if this vaccine will, or the COVID vaccines in general, will make them infertile or cause difficulty with conception. For this question, I stress that it has not been seen in clinical trials or in the millions of individuals who have been vaccinated here in the United States and around the world. The last question that I would like to mention is just the overall concern about the vaccine causing side effects, some in which people think may be worse than the actual COVID-19 infection itself. As a researcher directly involved in the trials, I provide the facts and data surrounding these side effects. And the most common of which we see, especially with the mRNA vaccines, are headache, chills, low-grade fever, fatigue, typically lasting 24 to 36 hours, but they do resolve. Most importantly, the risk of complications from severe COVID far outweigh the side effects from the vaccine. Another interesting observation I've noticed is that the first kind of wave of individuals we were vaccinating were very eager to receive the vaccine. However, now I'm seeing a little bit more questions and hesitation. I actually had one woman told me that the only reason why she was here is because her daughter would not allow her to see her grandkids unless she got the vaccine. Overall, dispelling the myths and keeping up to date with all the misinformation that is circulating has been my approach when talking to patients. And even most recently, when I was talking to the cashier at my local grocery store. I strongly believe that having these conversations are paramount and serve as another strategy in combating this pandemic. Thank you, and I look forward to answering the questions with Dr. Durbin about the vaccines. Thanks.
Thanks so much, Brittany. I'm now going to turn, I see lots of questions coming in, so I'm going to turn to the Q&A portion of today's session. And Brittany, I'm going to start with you. So we're now at a point where we have one vaccine that's received authorization for those that are 12 to 15 years old. What do you tell folks that are concerned about children or adolescents receiving the vaccine, since we know that they are generally at much less risk for severe disease?
Yeah, so what we've noticed is that children, especially adolescents and those under age 12, are less likely to have severe complications from COVID or have any symptoms at all. However, in order to reach herd immunity, in order to make sure everyone is protected and no longer transmitting the virus, it is important for children to get vaccinated, which is why we included children, the Pfizer and Moderna clinical trials, and we looked at safety of the vaccines in those groups and also efficacy, and they've proven to be both safe and efficacious in those groups. So I would definitely recommend children to get vaccinated.
Thanks, Brittany. Mm-hmm. John, a couple of questions for you about, that relate to Hopkins policy and COVID vaccines. The first is, how can those who have already been vaccinated let the university know what kind of documentation is required, and how will that work?
So we are building a vaccine management system right now. It will be rolled out by July 1st. That system, which will be very similar to the flu vaccine system, will allow you to upload documentation proving that you've had the COVID vaccine. The CDC COVID immunization card is by itself acceptable documentation. You may, if you got it at a pharmacy, have a prescription form or some other form of documentation. All of that can be uploaded. You only need one piece of documentation. We'll vet each piece individually at our end, and then you'll be registered in our system as having been vaccinated.
Thanks, John. And one more for you that's peripherally related to the vaccines, which is when we're doing the COVID testing on campus, are we able to detect the variants?
The answer to that is yes. The asymptomatic saliva-based testing we're doing works for the variants as well.
Thanks, John. Anna, I'm going to turn to you now, and a few questions coming in related to boosters and COVID vaccination. So the first one is it true that we're likely to need boosters in a couple months?
That's a great question. And I think the answer to that is no, we really don't know. The data that we have so far, I think, is incredibly encouraging in terms of the immune response. I do want to make it clear that anytime you get a vaccine or anytime you have an infection, your antibody titers are highest in the few weeks after that vaccination or infection, but they do come down over time, and that's natural. When you see that infection, then again, your body remembers it, responds, and gets higher antibody titers. So just because we're seeing titers of antibody decline over time doesn't mean that we need a booster necessarily. What we're going to be looking at are data around how long protective efficacy is lasting in the community. So far, again, those data look very, very good, particularly around the B117 or the UK variant, which has now become the dominant variant in this country. We're seeing excellent protection against that. Other countries have demonstrated excellent protection against the South African variant or the B351 variant, even though the levels or the ability of the antibodies as we measure them in a laboratory assay don't appear to recognize the B351 variant quite as well. We're seeing excellent protection in countries that are currently seeing that variant strain circulate. So just because we see variants around the world doesn't necessarily mean we're going to need a booster. What we're going to be looking at is looking at how well that efficacy is maintained over time. Are we seeing more severe cases in vaccinated people, for instance, at the end of the year? When we start to have data accumulate that sort of the protectiveness of the vaccine is becoming less or significantly less, and we're seeing increasing transmission of the virus, that's when we might start talking about a booster. But I always like to say, and I think this is very, very important, the best way we're going to prevent variants, the best way that we're going to sort of get everybody back to normal is to vaccinate the rest of the world. So right now it makes more sense to give those extra doses of vaccine that we have here in the United States to those countries that are still vaccinating their populations. I don't see the need for a booster shot, for instance, in the fall as yet. Now, the situation could change. It could be fluid, and that recommendation may change. We likely will need follow-up shots in the next year or so until this is globally contained, but we're not going to know until we see the data. Thanks.
Thanks, Anna. That was such a thorough answer that you anticipated some of my follow-up questions about boosters. So I'm going to, for now, move on to it. I'm going to stick with you, but for now, move on to a different topic. And this concerns this kind of mixing and matching of vaccines. So if someone has received the J&J vaccine, is there any reason, say if they're immunocompromised, for them to also think about getting the mRNA vaccine, so Moderna or Pfizer?
So that's a great question, and I will say that there are studies ongoing now looking at mixing and matching of platforms, because we know from experimental studies sometimes they act synergistically. They're not just additive, meaning that if you give one vaccine of one platform and a second different platform, you may see a better response with that second shot. And there are studies ongoing now in the UK to look at that. I think your question is particularly relevant around the immunocompromised population, because we know, depending upon what drugs you may be on, for instance, if you're a solid organ transplant patient, for instance, we know that the vaccines are not as immunogenic, do not induce as strong antibody responses in that population. And there are studies going on in this country to look at that population specifically and look at mixing and matching of platforms. I will say, just as a vaccinologist who's worked with vaccines for decades, I don't see a safety issue with mixing and matching of platforms. What we want to make sure is that we're getting the most out of that, though. We want to make sure that if we mix and match platforms, we're not seeing a reduced antibody response. And that has occurred in experimental animals with different vaccine platforms that I'm not going to go into right now. But the good news is, I think, we're looking at mixing and matching of platforms. Those studies are ongoing here in the US in immunocompromised, and then in the general population in the UK and Europe. And if we do see good results with mixing and matching, it of course greatly increases our flexibility around vaccination.
Thanks, Anna. Brittany, a few questions for you related to vaccines across several categories. I'm going to start with one, and I guess it's really how would you counsel patients with the following concerns. One is about financial impact that could potentially arise due to a vaccine-related injury, and what's your best advice for those who are concerned about that?
Yeah, that's also a good question. So as far as, vaccine related injury, vaccine side effects and adverse events are being tracked. It's highly unlikely that someone is going to experience a severe reaction to a vaccine, something we would consider like anaphylaxis, one of the things that we're most concerned about. Other types of injuries, with some of the vaccines, we've noticed that people may experience blood clots. Been seen with some of the Johnson & Johnson vaccine or AstraZeneca. As far as the financial impact of that, we would hope that any type of employer that is understanding of your vaccination status, and that you would be able to continue to work and also get the type of healthcare that you need. There's a tracking system through the CDC that's looking at any type of adverse reactions too, and this would be evaluated and looked upon. So the overall kind of financial impact to the person itself would, I would hope, would be none, that there's enough measures in place to help protect that individual. But again, I think it's overall rare that those occurrences would happen.
Thanks, Brittany. Another question for you. So you spoke about fertility concerns in your opening remarks, and I know that that's one that you hear about a lot. This is a follow-up question to that. And the gist is, without long-term studies so far, because that's just impossible given how long these vaccines have been around, how can folks feel reassured about potential future impacts on fertility when they're getting vaccinated now, but may not be thinking about having kids for several years?
Yeah, that's another good question. And this question comes up not only in regard to COVID-19 vaccines, but other vaccines in general. It was a question of concern regarding HPV vaccine, the human papillomavirus vaccine. And a lot of it are myths that have kind of stemmed from, communities that are against vaccination. What we can say that is right now, the data does not suggest that these vaccines are going to have any impact on fertility. We are tracking kind of side effects that are occurring. There are women who were in some of the trials for Pfizer, Moderna, who did become pregnant. And so, right now those pregnancies are being followed to term. I'm not sure if anyone has delivered yet, depending on what state they were. But we also know that there are women now who are, who've gotten the vaccine, who've become pregnant as well. So we're still evaluating to see that. Long term, we're not sure how this could affect, women in general. There's also been concerns too about, irregular menstrual cycles and things of that nature. We do know that women often have irregular menses from time to time. They may skip periods, they may have heavier flow. So right now, there's no direct kind of cause that COVID-19 vaccines are causing any type of disruption in menstrual irregularities, and also in any type of conception or fertility issues. So there's no data right now to suggest that. I think right now our focus should be on, preventing severe illness and complications, because what we're most concerned about is that, pregnant women, if they do get COVID, they'll have, severe outcomes from that. So, and also the baby, the fetus inside of them. So right now we are definitely recommending and encouraging pregnant women to become vaccinated, and anyone else who's at risk, the general public, women in general, we recommend getting vaccination. That is more important than any kind of possible theoretical risk that or unknown risk that could occur in the future.
Thanks so much, Brittany. John, I'm now going to turn to you with some questions that relate to university policy. And the first is, can you please talk us through who is being required to get a COVID vaccine, and are exemptions going to be granted?
So right now, we have announced that all students on campus in the fall are required to be vaccinated unless they qualify for a medical or religious exception. The medical or religious exception process is similar to the one we use for the flu vaccine and requires submission of documentation, a statement, etc., which is then reviewed. So that process, which will be available for both the mandatory flu vaccination required of all students, staff, and faculty on campus, and the mandatory COVID vaccination required of all students on campus, is the same. We may also end up requiring, that is mandating, COVID vaccination for any faculty and staff on campus. But up till now, we are strongly encouraging, but not mandating.
Thanks, John. Another question for you that relates to university policy. We know that some folks are worried about needing time off to get a COVID vaccine, or what might happen if they're not feeling well shortly after they receive it for a brief time. Can you talk us through what's available for folks?
Absolutely. So first, everyone should know that we're setting up multiple vaccination clinics on campus in an attempt to make it easier for everyone to get vaccinated. And Lainie will say a little bit more about that. We have also instituted a 2-day off policy after vaccination if you need it because you're not feeling well. And that applies to both the first dose and the second dose. And that complements the 14 days of COVID leave that has been available for over a year now if you're sick with COVID or in quarantine because you were in close contact with someone who has COVID.
Thanks, John. John, lots of policy questions coming in, so I'm gonna stick with you for a bit. Will international students have to get vaccinated before returning to campus?
The answer is no, although we encourage it as long as it's with a WHO authorized vaccine. We are anticipating that some international students will show up not having been able to be vaccinated ahead of time. And the same clinics that I just alluded to, which are starting this month, will also be available in the fall for anyone, but we're particularly thinking of international students who show up either unvaccinated or with a vaccine that was never authorized by either the US government or the WHO, in which case we will vaccinate or revaccinate you at no cost.
Thanks, John. And one more for you. For those who are already have a vaccine exemption, not for COVID, for a different vaccine within Hopkins, will they automatically have a COVID vaccine exemption? How will that work?
The answer is no, you do not automatically have a COVID vaccine exemption. And indeed, if you have a flu vaccine exemption from last year, you need to reapply. It's not automatically the case that you have such an exception in perpetuity. So you should just assume you need to apply for any type of exception, medical or religious, again.
Thanks, John. I'm going to turn to Anna now, but there are lots of policy questions coming in. So, John, I am sure we will see each other again during this town hall. Okay, Anna, question for you. Should someone who knows that they are currently positive for COVID, how do they think about timing to get the vaccine?
So if they're positive by PCR, meaning that they're currently infected, I think is what you mean, not just positive by antibody. But if they're positive by PCR, they're currently infected, the CDC recommendation is that they wait until they're asymptomatic and out of isolation. So those two things. My recommendation generally is that they try to wait at least 1 to 2 months. And I say that for a couple of reasons. The first being that you do have an immune response from your natural infection, and there is some concern that that immune response may affect your response to vaccination. That's why we have intervals between the first dose of a vaccine and the second dose of a vaccine, as we're seeing with Pfizer and Moderna. We know that if you give 2 vaccines too close together, you don't get a good response from that second dose. So that's the first reason I recommend waiting 1 to 2 months post your infection. The other is that you can have side effects related to the vaccine, and you can have longer term complications from your COVID infection that may not show up for a month or so. So to avoid some confusion, or confounding about is that side effect due to the vaccine or is it due to COVID, having an interval between natural infection and vaccination is a good thing to do. I also just want to make a note about one of the questions that Brittany answered, and she gave a very thorough answer about what happens if you may be injured from a vaccine. And I did just want to comment that although the COVID vaccines are approved under an emergency use authorization, they are still covered by the Vaccine Injury and Compensation Fund. So that is a fund that's available for people who are injured because of a certain vaccine, and you apply to that. That's a federally funded fund, which sounds funny, but yeah. So there is, even above what Brittany mentioned, there is a fund that if someone is severely injured from a COVID vaccine, they can apply to.
Thanks, Anna. I want to follow up on something that you were saying about protection or immunity for those who got COVID itself versus those who are vaccinated. So there's a lot of misinformation about this, including questions about which provides stronger immunity. Can you talk us through why it's still important to get vaccinated, even if you know that you have had COVID?
Sure, absolutely. So we don't know how long immunity to natural COVID infection lasts. We also know that just based on antibody titers, and again, that's just a proxy. It's not the complete picture in terms of your immune response. But we know that people who, for instance, may have had a mild COVID infection may not have as high antibody titers as people who had a more severe COVID infection. We also know, and I think this is important to note, that in the clinical trials that looked at antibodies following vaccination, the standard to which they compared was convalescent plasma, meaning plasma collected from people who had a natural COVID infection. And the antibody titers induced by the vaccines, by the mRNA vaccines, as well as by the adenovirus vectored vaccines, was as high or higher, in the most cases higher than convalescent plasma, meaning that you may get a better, higher antibody response with vaccination. And vaccination, I look at it a little bit like this. If you think of your natural infection as your first vaccination, and then when you get vaccinated, that's your boost, that's your second vaccination, that's going to improve your immune response even more. It's going to improve what we call your immune memory, meaning that your body is going to recognize that COVID more readily and really prime you for an excellent response if you come in contact with COVID, and will protect you likely for longer and protect you from more severe illness for longer than just natural infection.
Thanks, Anna. Brittany, question for you about long-term concerns. And I know we've already spoken about this a few minutes ago in this town hall, especially in the context of fertility, but I'm seeing more questions come in about this, so I want to raise it with you again. How do you, what advice do you give to folks who come to you and say that they're just worried about getting a COVID vaccine because it hasn't been around that long? We just don't know a lot about the long-term trajectory of this vaccine.
Yeah, that's a good question, and I definitely understand the concerns that patients and individuals in general have about the information that we have on the safety data, because it is still ongoing. One thing that I like to advise is that we do know right now that the overall long-term effects of COVID are pretty severe. We still have people who are suffering from long haul syndrome type issues. We know that it's had impact on people's respiratory system, on their heart functioning. The vaccine itself right now, we know that it is protective. We know that it's effective. We know that for the most part, safety and the most concerns as far as what we're seeing side effects are short term. There have been instances where we've been seeing people having blood clots and other types of issues, but for the most part, side effects to these are short term: headache, fatigue, chills, and then people are fine and then have protection. So I think the biggest takeaway that I try to stress to people is that your risk for severe illness for actual COVID infection is much higher, and the outcome of death and transmitting to other people who are vulnerable. So it's looking at that risk benefit ratio and also looking at your own individual health and well-being. And so for overall, I think this pandemic is affecting not only here in the US, but everyone in the world. That's why it's called a pandemic. And as a society, we have to really think about what's the best thing to do to kind of end this pandemic and protect ourselves, and most importantly, protect each other. So again, staying as much up to date on all the safety as we can. And when we are seeing any signals that say, something isn't right, we pause, as we've seen with a lot of the pausing in regards when we did see blood clots. We paused and we wanted to see, what's going on? Who is this affecting? Why is it occurring? And there's still ongoing safety monitoring. That's not going to end. So those are some of the things that I like to tell people when they do have concerns.
Thanks so much, Brittany. John, I'm going to turn to you now with questions that are coming in about university thinking, and several coming in related to how the university is thinking given CDC's recent guidance that has to do with masking, distancing, and those who are fully vaccinated. Can you give us a sense of the current thinking?
Sure. So we think bluntly that CDC's guidance was premature in a very specific way. Their guidance is scientifically grounded, but operationally impossible to execute. And that's because no one knows who's vaccinated and who isn't. And so if someone is unmasked in a setting where those who are vaccinated can be unmasked, but those who are not yet vaccinated should be wearing a mask, how are we to know the status of anyone who is unmasked? And as I noted earlier, we ourselves do not yet have a vaccine management system up and running. So we are absolutely not rushing to implement CDC's latest guidance. In fact, we're, as we have done all along, going to take a more conservative approach in the interests of preserving health and safety on campus. We have a tremendous track record of no or almost no transmission on campus, none whatsoever in classrooms and labs. A couple cases in office settings where our guidance was not being followed. And we're very proud of that track record, and we're intent on keeping up that track record. So, for example, while we're on our way towards easing distancing requirements, we are not on our way yet to easing masking requirements indoors. Outdoors, we've already eased masking requirements because the outdoor environment with so much air dilution is so much less risky in terms of transmission than the indoor environment. But particularly with respect to the indoor environment, we're going to continue for the time being to take a much more conservative approach.
Thanks, John. Another question for you. We spoke a little while ago about international students coming back to campus. This question is for an international student who has been vaccinated, but it's one that's not under EUA in the US. How will that be handled?
So it's going to depend on the specific vaccine. If it's a vaccine that is authorized by the WHO, it'll count just as much as if it was a US EUA vaccine. On the other hand, if it's an international vaccine that is not under WHO authorization, we will treat that person as being unvaccinated and will vaccinate them with a US vaccine.
Thanks, John. Another question for you, this time about exemptions. So some folks will be returning to campus, but they live in states that allow for so-called personal belief or philosophical vaccine exemptions. What is the university's approach to that?
If they are here in Baltimore on campus, our rules here apply. It's irrelevant that they came from a state that might have different rules.
Thanks, John. And one more for you about university policy. We spoke a little while ago about how if someone is already on record with the university as having an exemption for a different vaccine, not a COVID vaccine, they would still need to go through the exemption process. Are the medical criteria for the COVID vaccine similar to what we've seen for other vaccine exemptions?
Quite different. In fact, the only medical exception for the COVID vaccine is having a strong allergic reaction to the vaccine or its components. So if you get the first dose and you have a shock reaction and need an EpiPen injection, we're not going to make you get the second dose. But that's the only medical exception. It's not like with the flu vaccines and an egg allergy or anything else.
Thanks, John. Anna, I'm going to turn to you now. I'm seeing a lot of questions come in about the difference between EUA, meaning emergency use authorization, which is what we have in the US now for the J&J, Pfizer, and Moderna vaccines, versus full FDA approval. Can you explain why those two things, EUA and full FDA approval, are different?
Sure. EUA, or emergency use authorization, sort of says it all in its title. It's for emergency use. It was a mechanism that the FDA uses to allow a vaccine or a product, a medical product, or a diagnostic test be put into use before the entire process that's needed for full approval to be done. So I'll just give an example for vaccines. The FDA in general requires at least 6 months of safety data before they will consider a product for full approval. If we had to wait 6 months for EUA for the COVID vaccines, we would be in a very, very bad place right now. We've seen the numbers of cases decline rapidly since introduction of these vaccines. So essentially what the FDA says is we will evaluate safety, and they evaluated 2 months of safety data on everyone enrolled in the clinical trials for those vaccines that were approved under emergency use authorization. They said we will evaluate, we will approve the safety at 2 months, we will approve the efficacy data that are provided. You still need both safety and efficacy, whether you're looking at an EUA or full approval. So they then, after you've reached the 6-month safety data approval, then what the company does is they submit all of that data. And what's really amazing as you think about it now, we have data on hundreds of millions of people who have received these vaccines. We have more safety data today for these vaccines under EUA than we have had for any vaccine that has been moved forward for full authorization, full approval. Other things that go into the full approval process is that the company has to show that they can make several lots of the vaccine, and those lots have the same potency. It's called a lot-to-lot consistency study. And that's just to demonstrate that the company can make the same vaccine over and over and over, and the quality is the same. So the companies will be submitting their lot-to-lot consistency data as well, and that again takes some time to put together. If we waited for all of that, we wouldn't have COVID vaccines at the time that we do. So they're going to be, and Pfizer has announced they're submitting, has put forth their documents for EUA approval. We're thinking that Moderna will be next, and will send their documents in very soon as well. It will include an entire range, all of the safety data that they have up to this point, 6 months of safety data on everyone in the trials, as well as safety data from outside of the clinical trials that has been collected as part of our pharmacovigilance period. So there are more data that are submitted for full approval, but the EUA gives us the opportunity to use these vaccines sooner, which we really, really needed in the pandemic. I do always stress, though, that the vaccines have to be shown to be safe and efficacious as part of their EUA. So the safety studies are there, the efficacy studies are there. There's just a tremendous amount more now that will be submitted for full approval.
Thanks, Anna. Another question for you from your vaccinologist perspective. Is there a reason to get a COVID antibody test before going to get vaccinated?
Absolutely. I'm going to, I don't, this is a touchy topic, should I say, something along those lines. No, there's no reason to get an antibody test. There's no reason to get an antibody test after you've been vaccinated. There are certain groups that we do know do not respond as well to the vaccine, and those are people, as I said earlier, mostly solid organ transplant recipients who are on immunosuppressive therapy, people who have autoimmune disease who are on certain immune suppressant therapy. That is a conversation that they can have with their doctor. But I do always say that the antibody tests that are out there were not designed to measure the immunogenicity of these vaccines. That's number one. The antibody tests that were used in the clinical trials are different from the commercially available antibody tests that were designed really for diagnosis of COVID, not to look at an antibody response from a vaccine. The level that you get in that result, we have no idea what that means in terms of protection. We also know that people, for instance, may not reach the level of antibody that's designated as positive in these tests, but still have responded to the vaccine because there's other parts of the immune system that are very important for protection. And we've seen that in terms of some of the effectiveness data that are coming out from other countries. So I don't really see a need to get an antibody test. Some people do it because they're concerned. They don't know whether or not they've responded. Particularly, as I said, people who are on immunosuppressant therapy, and that's a discussion that they can have with their physician. But I think you have to know what you're going to do with that result. Are you going to change your progress or not? Are you going to change your plan or not? And as I said, right now, in terms of how we manage immunosuppressed populations who have been vaccinated but may have a poor antibody response, we are doing studies now, but we don't have a definitive treatment plan. So it's unclear whether even knowing whether or not you responded to that antibody test will be helpful. It may give comfort if you have a positive result, but if you have a negative result, it doesn't mean you didn't have a vaccine take. It just means that whatever antibody is in your blood system is below the level of detection of that test, and that test was designed to diagnose acute COVID, which means the levels that are treated as positive or negative may be different than if you're just looking at a vaccine response. It's a long-winded answer, but it's a complicated question.
I understand. Thank you. Here's another question that I'll call this a hot topic because we hear a lot about it right now. Anna, this is for you. For those who are fully vaccinated, can they still get COVID?
So the answer is yes. We know that some people who are fully vaccinated can be infected with COVID, and this is another podium that I get up, soapbox I get up on when I talk about vaccines, because there's a difference between infection and disease. And the goal of almost every vaccine that we have out there is not the prevention of infection. That's an incredibly high bar. It's the prevention of disease. And we know that most of the antibodies and the immune response that you make post-vaccination, it's given in the arm, so it's circulating in your blood. So you may not have enough antibodies to get across the mucosal of your nose and prevent that virus from landing in your nose and living there for a little bit. But what we do know is if you've been vaccinated, your chance of getting severe disease is minuscule. We know that all of these vaccines, and I want to stress this again, all of these vaccines that we have authorized under EUA in this country and WHO approved vaccines have incredibly high effectiveness against severe COVID, hospitalized COVID, and death. And I mean 85% and higher. That is incredible. So although you may be infected with COVID post-vaccination, the likelihood that you're going to get sick is incredibly small.
Thanks, Anna. And I'm now going to ask you a cousin of the question that I just asked you, which is, can someone who's fully vaccinated transmit the virus that causes COVID to others?
So we think that it's possible, but we also believe that and the data are coming out to show this, that it's reduced, the ability to transmit virus is very, very low. So we know from some of the vaccine trials that were done here in the US and in Europe, what we're seeing, the data are coming back showing that there is a marked reduction in transmission of the virus. And I really think that that's for a couple reasons. I think, as I said, even though you may be able to be infected by the virus, your immune system is working on that. So I think it's reducing the amount of virus that's in your nose, and it's reducing the time that virus may be there, so that there's a smaller risk, there's a narrower window for transmission. And the clinical trials are bearing that out. We're seeing a great deal of reduction of transmission. And I think that's also, that's one of the reasons we're trying to get, as Brittany mentioned earlier, to herd immunity. Because if we have enough people vaccinated and fully vaccinated, transmission is reduced, the virus doesn't have as many places to go, and we're going to get, hopefully back to normal in not too long. But we have to vaccinate the world, and that's another big point. We're not isolated in the US. We need to vaccinate the world if we're going to really, really control the pandemic.
Absolutely. Thanks, Anna. John, I'm going to turn back to you with some questions about the university approach. So Anna talked about antibody testing, but specifically to the university, will we be using any kind of antibody testing as proof of vaccination?
No, we will not. The proof of vaccination will be exclusively by documentation uploaded to our vaccine management system after its launch on July 1st.
Thanks, John. And you and I have talked a bit during this town hall about those who already have vaccine exemptions on file. We talked about what that means from a medical exemption perspective. What about, and I'm seeing more questions come in, so I'm going to put this back to you, for those that already have religious exemptions on file with the university, how will that work for the COVID vaccine?
You'll need to submit it again, specifically in the context of the COVID vaccine.
Thanks, John. And another question for you about university policy. If someone is enrolled in an online degree program, meaning they do not come to campus, do they need to have proof of vaccination?
The answer is no. The mandatory vaccination requirement for students is exclusively if the student is coming onto campus.
Thanks, John. And one more for you. For those that are fully vaccinated, is there still a need to comply when on campus with other mitigation measures?
The answer is absolutely yes. We have not in any way changed our guidance to distinguish between vaccinated and unvaccinated individuals as of yet. When we do move into phase 3A on July 1st, the difference will be the testing requirement. So those who have submitted proof of vaccination will not have any required testing. Those who have not submitted proof of vaccination will be required to test 2 times a week if they are to be on campus. And I'm talking about students, staff, and faculty.
Thanks, John. And a question for you. For someone who has had COVID, meaning they tested, they know that they had it, they're still experiencing some lingering symptoms of COVID. What should they be thinking in terms of getting vaccinated?
I think that's a very thoughtful, great question. And some of it depends upon what the symptoms are. And the reason I say that is we know that people who have had COVID and get vaccinated sometimes have more significant side effects from that vaccination. And they describe it almost as COVID-like symptoms again. Now, the good news with that is they're relatively short-lived, meaning days as opposed to the very long-term complications. So I would say that depending on how severe those long-term complications are, they can wait. The original recommendation from the CDC was to wait 3 months from COVID, and CDC later revised those. They came up with 90 days because we, at that time, knew that people generally had 90 days of protection against reinfection if they were infected once. So again, that's a discussion that I would have with my physician, and it depends somewhat on the severity of the complications that they're having, and how long it's been that they've been having those complications. For the most part, they can get vaccinated even in the presence of some of those complications, but I think they do need to be aware that they may have some recurrence of some of those complications from COVID, although they only, what we've been seeing now in the general population that we've observed these side effects, they tend to last only, as I said, a few days.
Got it. Thanks, Anna. I have another one for you. So we've heard a whole lot, I think, especially those of us who are not vaccinologists have learned a whole lot this year about the spike protein and what that means. How is a vaccine able to target the spike protein when does it exist in other places in the body? Like, how does it know to target the right thing?
Oh, that's great. So what happens is when you're given a vaccine, the way these vaccines are administered, and it's really fabulous technology, and I think we're going to be seeing a lot more of these mRNA and virus vectored or other vectored vaccines in the future, because they can be made relatively quickly and are very specific to the pathogen. So we take the genetic material of that spike protein, and for the mRNA vaccines, they're put in a little fat bubble to get into your body. With the adenovirus vectored vaccines, the virus itself acts as sort of a Trojan horse and brings it into the cells in your body. And then your own cellular machinery makes the spike protein. It makes the COVID spike protein, and it looks just like the COVID spike protein that the virus itself makes. So your body is seeing, because of the vaccine, your body is seeing the spike protein in its natural formation. And so you make antibodies against that naturally formed spike protein. And then when the virus infects, natural virus infects, your body recognizes it, sees it, and acts against it. Now, we do know that the genetic sequence of the vaccines is one of the original strains of COVID, the Wuhan strain of COVID. So there have been mutations, and people have probably read about this in the press. There's been mutations, and we have these variants of concern. And that means that the genetic sequence of those variants of concern is different than that which is present in the vaccine. But as I mentioned a little bit earlier, the good news is the vaccines recognize enough of that big spike protein that they appear to be extremely effective at prevention of severe disease caused by the variants of concern, particularly the South African variant, which is more difficult, I would say, in terms of antibodies to bind to, but we're seeing very, very good protection against the South African variant with the mRNA and the adenovirus vectored vaccine. So that's good news.
Thanks, Anna. And we're We're nearing the end of this town hall, but I want to ask you another question that we spoke about a little while ago, but I see it's variations of it are coming in again, and it's so important right now. For those that tested positive PCR tests for COVID, can they rely on the immunity that their body produced from that infection, or should they be getting vaccinated?
They absolutely should be getting vaccinated. As I mentioned earlier, it appears that the immunity, at least measured by antibody response that you get from the vaccines, is as good or better, and for the most part better than a natural infection. And it will only improve, it will only make your immunity last longer. And that's the important part. If you get vaccinated post-infection, you're going to see a really nice boost in your immune response. You're going to be elevated to a level of excellent protection that will likely last much longer than just a natural infection.
Thanks so much, Anna. And John, I'm going to turn to you. I think this is going to probably be the last word in this town hall. You mentioned in your remarks earlier that students who are not vaccinated will be tested twice a week on campus. And this is a clarifying question. Does that mean that if a student is on campus unvaccinated and has an exemption, are they still going to be tested 2 times a week?
The answer is yes. In fact, the only students on campus who are unvaccinated will be those with a medical or religious exception, and they will need to be tested twice a week. All faculty and staff who are unvaccinated, even in the absence of a mandate for vaccination, will also need to be tested twice a week if they are on campus. If the university mandates vaccination for faculty and staff, which is not now the case, then the only faculty and staff on campus who won't be vaccinated are those with a medical or religious exception.
Thanks, John. And we're closing in on 2 p.m., so I'm going to wrap up. I'd like to thank John Links, Anna Durbin, and Brittany Feijoo for joining me today, and give a big thank you to everyone who joined us, and especially to those who submitted questions during this session for our experts to answer. If you have not yet received a COVID vaccine and are looking to do so, we are now hosting a series of vaccination clinics for Johns Hopkins affiliates in different locations on campus. The first of these clinics will be happening tomorrow. It will be on the Homewood campus from 1 p.m. to 6 p.m. at the Glass Pavilion. And you can learn about future COVID vaccine clinics that will be on campus at covidinfo.jhu.edu. If you haven't already done so, please consider taking a moment to complete the survey on the viewer webpage so we can better understand vaccine-related concerns among our affiliates. Your participation in that survey is both voluntary and anonymous. This town hall will be archived and available for viewing, and I hope that you've enjoyed this session. Please remember, the COVID vaccine helps us to protect ourselves and our communities. Thank you, and stay safe.